So, just a little bit about myself. I am from Buffalo, New York. For those of you who's been to the United States. Okay, oh, a lot of you, how lovely. Okay, so it's rather large, as you know. That's where I grew up. That's my cute little house that my mom still lives in. I'm sure she's thrilled that at least the address is not up. But there's a lot of snow in Buffalo. It's very, very cold. It's about 2 hours outside of Toronto, and I live about 15, or my mom lives about 15 minutes from Niagara Falls, which is absolutely beautiful. I went to Damon College there. Damon College is an undergraduate school. It's a very, very small school. There's probably more people in this room than there is at Damon College. So the smaller the school, the more menacing of a mascot you need. That's pretty much how it works in the US. So I was a licensed physio by the time I was 22, so started rather early, which was nice. Got my first job down in Raleigh, North Carolina, and went to the University of North Carolina to do my graduate studies. And so I did athletic training there, which I don't think exists in this country. It's probably analogous to a sports therapist. So athletic trainers are first responders on the field. They're the person who's going to run out if somebody's injured when they're on the field. This is where I started my sports medicine studies. And there I got to work with women's basketball, football, and rowing. And so that's really where my sports medicine stuff started. After that, my boyfriend and I of 7 years broke up. My life was clearly over. So I packed up my Jeep, moved across to Phoenix, Arizona, drove as far away as I possibly could, and searched for sun. And for those of you who have been to Arizona, it is very, very sunny there. It's probably about 30 or 35 degrees there right now, so it's extremely hot. And so I found exactly what I was looking for in sun. And then I randomly met a guy named Mark Verstegen, who had just opened a company called Athletes Performance, and it's now known as Exos, if any of you are in the strength and conditioning field. I started working there. I worked there for about 13 years of my life. Left there as a vice president of that company. These are some of the facilities that I oversaw, the physiotherapy in these facilities. So in these facilities, we basically saw professional athletes of every sport. So football, basketball, hockey, American football, all different types of sports. And during that time, I got the opportunity to begin working for the LA Dodgers. So I got to move out to LA, nice beachy town, lots of avocados, really lovely, and became the head athletic trainer for the LA Dodgers. So being the head athletic trainer for a major league sports team in the United States, vice president of a company that is now over 5,000 people are really not two jobs you should have at the same time. So I quit both. After a period of time, I thought I committed career suicide. I thought I'll never get another job again. But quit both jobs, did my yoga teacher training, became very Zen-like, and eventually moved back to Phoenix and took a job as the head athletic trainer and head of sport performance for the U.S. men's national team. We like to call that sport soccer in the U.S. I'm not really sure why. I do call it football and American football. I at least know that rule. And then once Jurgen Klinsmann left and I left, he was the coach that I worked with, began working at a gym out in LA again and consulting, and we mostly saw MMA fighters there, actors and actresses preparing for roles, and then really rich people who wanted to be one of those other two things. Helped them get that off the plate, and then started working at A.T. Still University. And I'm sure many of you know who Andrew Taylor Still is. He is the founder of osteopathic medicine. So I'm a professor there in the Doctorate of Athletic Training program, and also had the opportunity to start my own education business called Structure and Function Education. And so we teach dry needling in that company. And so in my country, the A word is a really awful word, right? The acupuncture word. So I'm really excited this weekend that I am able to utilize the word acupuncture as much as I want, because I don't get to use that word in the US. So now what I do is I have like a concierge practice where I basically consult with different organizations, different teams, and different athletes, and I travel with athletes and take care of them top to bottom. So whether that's from a fitness standpoint, from an injury standpoint, from a recovery and regeneration standpoint, lots of different things. And so instead of seeing 20 people a day like I used to, now I see one person maybe over the course of the year and really take care of their health from top to bottom, which is kind of an interesting and different sort of practice. And so just to kind of give you a little background on my needling experience, like I said, I'm not really allowed to utilize the word acupuncture in my country. That's definitely a four-letter word, so we utilize the term dry needling. And so I know as I lecture and travel throughout the world, I understand that dry needling has a very different connotation to it than it does in the US. I'm sure dry needling, from what I understand here, is more of a trigger point-based therapy technique. Is that correct, what I'm understanding? And that's not what I do whatsoever. Trigger point, I work with a lot of patients who are in their season, right in the middle of their season, and it tends to make them rather sore. So that's not the approach I take. I do tend to take more of a Western medical acupuncture approach. I started my needling career probably back in '08 when I first started with the Dodgers. I had heard about needling, and so that's typically what I just tend to call it, is needling. So that way I'm not talking about acupuncture or dry needling. I just usually say needling. And I had the opportunity to start to study with a man named Dr. Yuntao Ma, and called him, and because of my crazy schedule, I wasn't really able to go to a class. So I called him, and him and his wife said, well, yeah, why don't you just come to the house and I'll just train you one-on-one. And I'm thinking, now that I teach needling in the States, I'm thinking, I'm not inviting anybody who randomly calls me to my home to teach them needling, the most bizarre thing. So what I did was I just personally studied with him over time, and then eventually began teaching with him, and then eventually, like I said, had the opportunity to branch out on my own. So it's been quite the journey that has led me here, which is really, really exciting. And so really what we're talking about today is recovery and regeneration. And I know I kind of gave you that background because I need you to understand, in the States, I work with 18 to 35-year-old healthy men. That's it. They have very few, if no, comorbidities. So needling works really, really well on these guys, right? I don't work with elderly. I don't work with any other type of population. God, I haven't worked with a female since '08, quite frankly. But I think the physiology is the same. But my point is just that even though my perspective is that 18 to 35-year-old professional athlete who is really just sort of pushing themselves over and over and over again to the limit every single day. But hopefully we can still take these concepts of recovery and regeneration and apply them across the board to your population. So I'm really hoping we're able to do that. For me, recovery and regeneration is really, really an important thing when it comes to working with my clients. The whole purpose of me working with them is so they can continue to train and compete. Nobody wants the physio to tell them that they have to take time off, or that they can't practice, or that they're unable to compete. If that's the advice I gave my clients, I would not have any clients. So the whole point is to make sure I can support their physiology so they can do what they need to do. They are unbelievable physical specimens, and I just need to be able to support them, whatever that may be. And I use a lot of different tools to do that. And so needling is one tool that I utilize in order to help their recovery and their regeneration. But make no mistake, it is a tool, right? It's not my philosophy. And I think in the States, people mistake their philosophy with tools all the time. My philosophy is unwavering, and it's always to restore and maintain the homeostatic balance of my client, whether that's biomechanical, biochemical, biopsychosocially, whatever that may be. And whatever tool I choose to use helps support that goal. And their goal, right? My goal is to support their goal. Their goal is to train and compete. And that's what they want to do. So the point isn't about sticking needles in people. The point is to support their physiology in whatever way I can in order to help them attain their goal. So this is from my book, Bridging the Gap from Rehab to Performance. This is certainly not my own concept. It was just the easiest graph I could use without infringing on copyright issues. So the concepts of supercompensation when it comes to training are really important. Does anyone do a lot of training in here or work with athletes on any level? Some people? Okay, great. So when we talk about supercompensation and the concepts of training, here we have performance and here we have time. What we want to do is we want to introduce a training stimulus which decreases somebody's performance for a very, very short period. And then we introduce some recovery techniques or give them time. And ideally what happens is over time they begin to supercompensate. So they become just a little bit stronger, just a little bit faster, just a little bit better. And then we introduce another training stimulus which dips their performance again, ask them to recover, and then the process of supercompensation goes over and over and over again. What happens when athletes don't recover is that we introduce another training stimulus, but they're not fully recovered, so we get this major decrease in their performance. And we get this downward spiral. And very soon you have what is considered an overtrained athlete, which is not good. So a lot of times we will utilize the concepts of overreaching in strength and conditioning, where I want my client to train in a fatigued state. That's second half stuff. That's fourth quarter stuff. There are times when my client is not fresh. They are absolutely exhausted and fatigued. And I need to make sure that I train them in those states for small, short periods of time and certain types of microcycles throughout the year in order for them to realize from a physical standpoint they can handle it and from a mental standpoint they can handle it. And strengthening and conditioning, that's known as overreaching. And it does result in a short-term decrease in their performance. And that's okay. We accept that and we move on. However, if you periodize overreaching poorly, or it happens over a prolonged period of time, what we end up having is an overtrained athlete. And that's when there's an accumulation of training stress or non-training stress that results in a long-term decrease in their performance. And that is not what we want. So overtraining often is caused by too much concentrated load in a given period of time, continuous non-progressive loading, or monotonous training where guys just add volume, right? I'm a physio first, a strengthening and conditioning coach second, but as a physio, I love 3 sets of 10, right? Oh, that's like my favorite set rep scheme. I can watch it, I can load it, I can coach it. It's awesome, right? But that's not how people move. People move in 6 sets of 1. Or 5 sets of 1. And they have to do that over and over and over again. And so what happens is sometimes people just add volume. If 20 pounds is great, 30 pounds is better. If 3 times a week is good, 5 times is better. And more load is not always better. But that's the way a lot of people do. Continuous failure in training and competition. We see this a lot. When athletes are performing poorly, they think I need to work harder, I need to work more. So they start getting into the gym work and they overtrain themselves. And then finally, their lifestyle, right? I work with clients who are 18 to 35-year-old millionaires, right? So they're burning the candle at both ends. They are going out, they're drinking, they're partying, they have lifestyles that don't allow them to sleep very well. And so these are lifestyle things. And so really what this is, it's not an overtraining issue, this is an under-recovered issue. And this is a very different thing than overtraining. Most of my clients can handle a lot of load. What they can't handle is not being able to recover so they can introduce another stimulus the next day or another competition. Under recovery definitely causes long-term decrease in performance. So one of my main jobs with my clients is to make sure that they are recovered enough, whatever their lifestyle is. Obviously, I do counseling with them, we talk about it. When you're working in a concierge type situation, you have the opportunity to talk about these things with your clients. But at the end of the day, they are 20 years old, right? So they're gonna do what they're gonna do. So my job is to make sure that these people recover as best as they can. And we know it's not just about, like I said, the anatomical stress, or their recreational or prescriptional drug use or poor sleep patterns. Right, in the US, we're traveling 3 time zones when we're in LA, and then we go to play the New York Mets. That's 3 different time zones. So their sleep habits are really, really poor. Nutritional habits are poor. When you're in the lower leagues of baseball, I mean, you're literally eating the best meal that you can from a gas station, right? So trying to educate, okay, you want to get beef jerky, don't get the hard-boiled eggs. And trying to just help them from a nutritional standpoint, but there's a lot of physiological and biochemical stress. From an environmental standpoint, same thing, lots of different terrains in the US. So when I was with the Dodgers, every time we would go to Denver and play, there would just be tons of injuries. It was like my nightmare. We would go to play the Colorado Rockies, and it's called the Mile High City for a reason. It's a mile high up. And so everybody would just have multiple issues, headaches, their reaction time was poor, they'd be running into walls, dislocated shoulders, our coaches, there's heart arrhythmias, everything, because of all of this different stresses from altitude. So lots of different things cause stress within my patients. And I need to not just think of them as biomechanical humans, right? I need to look at them as a whole and understand that all of these things are really affecting how they feel. So recovery, people like to use the terms recovery and regeneration interchangeably. Not really the case. Recovery are activities or supplements that help an athlete physically or psychologically overcome the stress of hard training, competition, and life. Regeneration is an actual planned training unit. So we will utilize regeneration units in order to help our patients recover. I know it seems like semantics, but it is important. As we look at a weekly schedule potentially, on a Monday, Thursday, let's say maybe we work on activation, we're working on linear speed, maybe we're working on some type of strength and power, and then we are always going to end with some type of regeneration unit. Tuesday and Friday, maybe we work a little bit more multi-directional speed. Strength and power still maybe over here. We did an upper body push and a lower body pull. Now we're doing upper body pulls, lower body pushing. We're just sort of periodizing our stimulus. And then maybe Wednesdays is an entire day of regeneration activities where they're getting massage or mobility work and prehab work and all of those sorts of things. And then Sunday is really just sort of an active rest day where they are taking a walk, they're taking a walk with their dogs, they're hanging out with their kids, they're doing anything that's sort of just not in the gym. And so this is a very typical sort of off-season program, obviously not what happens in season. So as we look at these concepts of active recovery and passive recovery, there are different things that we do actively and passively. Active recovery are low, non-impact things that help our athletes sort of feel better. Passive recovery techniques result in no energy output from the athlete. So they're laying there on the table, very, very happy, and that's when I have to do the majority of the work, which is annoying. So that's why I got into needling, because I got really tired of digging my elbow into people. So active recovery techniques a lot of times are pool workout, self-massages like foam roll, massage sticks, low impact activities, light activities. And then passive recovery type things, again, cold tub, contrast bath, massage. This is where acupuncture fits in, nutrition, complete rest. So as we sort of look at all of these different things from a recovery standpoint, this is really where acupuncture fits in. It really fits more into these passive recovery techniques or passive regeneration techniques that we can utilize to help our athlete recover. So why is this important? Sue, this is a needling talk. We're 15 minutes in. You haven't even talked about needling. It's important to understand why we're doing needling, right? We have to start with why. If we don't understand why we're putting needles in people, there is no point, right? The point of the treatment isn't to stick needles into people. The point of the treatment is to help them achieve some physiological state that helps them achieve their movement goals. It's always about improving their movement. It's always about improving their function. And we need to understand why. And if we can understand why needling works, then we can understand better how to manipulate it to better help our patients achieve their goals. So when we look at this concept of starting with why, you can't really see that middle one here, but why, which is unfortunate because it's sort of the main point of the slide, why is the center, right? That's our motivation. How is the process and what is the product? So, for example, when I have a client come to me and he says to me, I want to improve my first step quickness. Really? You want to improve your first step quickness? Yeah, I want to steal more bases. Okay, why? Well, because I want to get a new contract. Really, why? Why do you want to get a new contract? You already have $10 million in the bank. Well, because I take care of my wife and I take care of my kids and then I take care of her family and I take care of my family and my brother and his children because I'm the first person to ever make it. And so I need to have another contract because all of these people, there's like 35 people relying on me to take care of them. And if I don't get another contract, then I'm going to be disappointing 35 members of my family that I'm taking care of. Oh, okay, so you want to run faster. Okay, got it. So two totally different things, right? If you don't understand the motivation for your patient, you're never going to be able to help them. So for me, starting with why is really important, and we can apply this from a clinical standpoint as well. Every clinician knows what they do, right? The motor skill of needling is pretty simple. We could pretty much teach it to anybody, and as long as they don't put it in an anatomically poor location choice, it's a pretty easy motor skill to use. So everybody understands what they do, and most of us understand how we can manipulate the things we do in order to get a different result, right? If I put needles in one place versus another, maybe that changes the result. If I do some different needle manipulation, great, maybe that changes the result. Awesome. But when we really begin to understand why are we doing something? What's happening there? Then we can make better informed clinical decisions. And then we can also really start to figure out the minimal effective dose, because again, I'd rather have less needles with a great physiological dose. I'd rather use 12 needles than 24 needles if that's possible. So if I can understand the why, I can make better informed clinical decisions. If I can make better informed clinical decisions, hopefully I have better outcomes. So let's look at why do we needle for recovery? It's multiple reasons, but the first reason we're going to talk about is this balance of this autonomic nervous system. It's all about the balance of parasympathetic and sympathetic, right? So our parasympathetic, rest and digest, our sympathetic, fight or flight, right? We have our heart rates slower, our breathing rates decrease. We can sleep here, we're digesting, we're recovering, all of these awesome things that happen from a parasympathetic standpoint. From a sympathetic standpoint, this is where we are fighting for our lives. We have a huge increase in our heart rate, our breathing rate increases, our pupils dilate so we can see the enemy that's coming at us. We have an increase in blood flow to the muscles, so we're not digesting really well. We're ready for battle. That's the whole point of the sympathetic nervous system. So the problem now lies in that so many people are stressed out, and there's always this constant stimulation from phones and lights and iPads and all of these things, that we start to really sort of live in a sympathetic state. So what happens is this thing that was supposed to protect us and help us survive is now sort of the state that we're constantly living in, and that's problematic. How many of my clients have digestive issues, right? I mean, oh my gosh, in the US, you go to a restaurant and it's like gluten-free, dairy-free, vegan, vegetarian, non-GMO, right? There's a million different things that people are searching for better digestion. But what if we were able to allow them to tap into that parasympathetic nervous system and simply allow their body to digest better? It would probably go pretty well. So we need to be living more in this parasympathetic state and transfer over to that sympathetic state when needed. But the problem is we're living here. And so we know this, right? It's straight yin and yang. Neither system is good or bad, right? But we need to be able to transfer in and out of parasympathetic and sympathetic. One is not good, one is not bad. They are very necessary at different times, and we need to be able to understand and how to tap into some of those things. We live in the sympathetic state. The clients that I work with, I know I like to make fun of them because they are young millionaires, but they are rather stressed out. There is a lot of pressure on them to perform. There's a lot of media. They all have families that they are trying to support. And I know when you look at $10 million, you think, really, you're probably okay. But when you come from nothing, all of a sudden, these things are very stressful to you. And so it's really about allowing this balance between the two. We know, and I'm sorry, some of my references are getting cut off, but you do have them in the back. And I have made some updates to the presentation, which I know you're thrilled about as you look through. Yeah, sorry. I'm that person that, like, yesterday was changing slides, so. But I'm happy to email updated slides so that way you can have them, the updated versions, absolutely. But we know that when we start utilizing needles, different things happen, right? We see some activity in the prefrontal cortex, which we know that the prefrontal cortex mediates behavior and somatic responses to stress. We know that the periaquetal gray matter is involved from processing information from somatic afferents during acupuncture and electroacupuncture as well. We know that we get opioids and GABA release that are stimulated when we insert needles into people and when we attach electroacupuncture to those needles as well. And then at the hypothalamus, same thing. We know that we can affect and help regulate the autonomic nervous system. We do also know that negative perceptions may increase a sympathetic effect. So that's really important for me, because when I have a client who is afraid of needles or they have a negative perception of what's about to happen, no matter how much research backs up that what I'm doing or where I'm placing my needles might be more parasympathetically stimulating, if their perception of what they're about to receive is negative or they're a little bit stressed out about it, it ramps up that sympathetic nervous system. And so I need to be able to manage that expectation for people. We know that amino acids regulate nervous activity, and that this is really sort of where it's at, right? How can we begin to modulate and place our needles and manipulate our needles in a way that may be able to affect different neurotransmitters, which may have specific effect on different disease processes? Wouldn't that be nice, right? But it's not that clear cut. So we know this is not new information. You guys have seen this graph before, I'm sure. We know that as people process pain, we stimulate A delta fibers and C fibers. A delta fibers are those bigger myelinated fibers, pain fibers. C fibers, unmyelinated, really small. So we transmit information to the central nervous system at different rates. A delta a little bit faster than the C fiber. That A delta fiber is that sharp, immediate pain that happens when you slam your finger in the door. And then after a while, it begins to throb, and that's your C fiber pain. And we know that that's going to go up to the thalamus and to the cortex. When we start inserting needles into people, we stimulate that A beta fiber and the A delta fiber. So again, that's that sharp prick that sometimes people feel when we insert the needle. But the A beta fiber is very interesting because there's palpation there. And so when we begin to palpate and we place the tube and our fingers on the needle, or on the skin of the patient, we're stimulating an A beta fiber. An A beta fiber is really large, very, very myelinated, and transmits information faster than the A delta fibers, right? So again, think about slamming your finger in the door, right? After your initial reaction of like, oh God, and when you put it to your mouth, you immediately touch it because you're trying to stimulate that A beta fiber. And that's gate theory type stuff, and that's exactly what happens here. We can presynaptically inhibit pain through the spinal cord by stimulating endorphin cells and endorphin release presynaptically at the spinal cord. We also know that we're going to stimulate the periaquetal gray matter, which can also now postsynaptically inhibit that pain. But we're also going to go up here to the forebrain, hypothalamus, the pituitary, and we're going to be able to release some adrenocorticotropic hormone into the circulatory system to help modulate cortisol. Cortisol is a stress hormone, or can be a stress hormone, depending on when it's released. And so the interesting part about this, because I'm not really talking about pain, I'm talking about inflammation. So this part of this graph is really interesting to me, really, really interesting, because it's really what defines the HPA axis. So the HPA axis is the hypothalamus, pituitary, adrenal axis. And what this HPA axis does is it helps us modulate inflammation. So the hypothalamus releases corticotropic releasing hormone. That stimulates the pituitary gland. The pituitary gland stimulates adrenocorticotropic hormone. That stimulates the adrenals. The adrenals release cortisol, which gets into the bloodstream. And so we have this sort of modulation of inflammation that sort of just naturally happens in the body. When we have injury, we know that injury creates inflammation. Inflammation results in the production of mast cells. Mast cells drive cytokines. And cytokines, so we heard Marie earlier talking about interleukins. So interleukins are one type of cytokines. There's lots of different types of cytokines. But the interleukins are really, really interesting because these cytokines help drive this HPA axis. So anytime you have this injury, what happens here is the body's trying to modulate it, and the body is trying to move this process of inflammation to resolution as fast as it can. Sometimes that takes the acute stage of inflammation can last 3 days, 7 days, 10 days. It depends on the health of a person's system. It depends how well they're able to move that process to resolution. But this is basically what's constantly trying to happen. So again, the interesting thing in this is that we know when we insert needles into people, we can stimulate a lot of different cytokines, but specifically the interleukins, which I think will then, as we've already said, stimulate the HPA axis. So by inserting needles into people, I can begin to modulate their inflammatory processes and help them move to a state of resolution faster. And I think that phrase, right, that phrase has really hit home with me in the last 6 months. We like to talk about things that are anti-inflammatory, right? Anti-inflammatory medications, anti-inflammatory therapeutic interventions, and that's not really what it's about. It's about moving through the process of inflammation as fast as we can in order to get to those other stages of healing. So anything I do isn't about being anti-inflammatory. I want to move through resolution quicker. And I think that's a different way to think about it. And when I start inserting needles into people, I can help stimulate this HPA axis and allow them to move through that process of inflammation resolution quicker. So anyway, this humoral response, right, because it's based on circulation and because it's based on concentration gradients and what's going on, it takes time. And so this happens over the course of several days and is one of the things that we can maybe begin to think about from a frequency standpoint of how often do we want to needle people. So if we know that this takes several days, maybe we want to try to get ahead of it, but we don't have the exact information. We don't know exactly if it takes 72 hours or 76 hours or 68 hours, but we have an idea. But the interesting thing now is I begin to continue to look at why. Why am I putting needles into people to help them recover? This is another interesting thing. The cholinergic, I never say this word right, cholinergic anti-inflammatory pathway. And the cholinergic anti-inflammatory pathway is neurally based. So before we said it was humorally based, right? So it's based on circulation. This is based on the nervous system, which is very, very interesting. Because instead of this hormonal stuff, we have a way to tap into this anti-inflammatory pathway at a faster rate. It's like lightning. And so what happens is we can help stimulate the production of acetylcholine via nerve stimulation. And when we stimulate acetylcholine, we know that is one of the primary parasympathetic stimulators in the body, so we can get some vagus nerve activity. Vagus nerve activity is going to slow our heart rate down. It's going to slow our respiratory rate down. It's going to improve our gastric motility. Those are all really good things when I'm trying to help somebody recover. We know that macrophages that are exposed to acetylcholine are effectively deactivated. So basically, it's going to help inhibit the release of tumor necrotizing factor from macrophages. Macrophages are one of the key players in inflammation, because as long as there's macrophages there, everybody else in the area has a certain job. And then when macrophages leave the area, it clues everybody else that's hanging around to say, oh, all right, macrophages are gone, this party's over. It's like the cool kid leaving the party. It's like, oh, the hot guy's gone? Time to leave, right? Because once the cool kid leaves, then the party's sort of over. Same thing here in physiology. Once the macrophages get out of town, everybody decides, inflammation must be over. Let's move on to the next phase. So if we can deactivate some of these macrophages, we can decrease inflammation faster in the area, theoretically, and we can move this process of inflammation to resolution faster. So this is really interesting. This is why we're going to stimulate your nerves, which not only am I going to talk about, but I know Gus is going to talk about later this afternoon too, which is really just sort of a fascinating new thing that I've been getting into over the last probably 6 to 12 months. So we're going to talk more about location in a bit. So I want you guys to just sort of file this information away. We're going to bring it back. So we know we've got two different things here when we insert needles, and everything's happening at the same time. We like to talk about these physiological processes as if they are separate occurrences, because it's easier for us to understand, it's easier for us to process. But we need to understand that these things, a lot of them are happening at the same time and together. So we have this diffusible anti-inflammatory network that's driven more off of hormonal responses and the circulatory system, which takes time, right, several days in order to do. But now we also have this neural pathway that we can help move to resolution of inflammation quicker. So it's important to know that we have both of these pathways. Now, when we start adding e-stim to people, we can make this cholinergic anti-inflammatory pathway happen even more. And so I used to be that person who never utilized electric stim with my needles at all. And really it's been in the last several years as I continue to read the research and see how powerful it is that I've been getting into it more. So basically e-stim just sort of drives this process even faster than just by inserting the needles. So ultimately, from a why standpoint, again, it's not about being anti-inflammatory. It's about moving through the process of inflammation quicker. It's about moving to resolution as fast as we can. So when I have an athlete who is feeling under-recovered, that means a host of different things. Not necessarily painful, but they're tired, they feel miserable, their legs are heavy, their willingness to train is decreased, they're not sleeping well. All of these things, if I can help them generally move through this inflammatory process faster, that's going to be a good thing. And then also this balance of that autonomic nervous system is absolutely key. So those are our whys. How do we needle for recovery? Well, we know needle manipulation has a lot to do with it. So needle manipulation is required to stimulate local, segmental, and systemic effects. Adding some e-stim to that can also help with pain and inflammation. Pistoning, this is why I don't like utilizing that term dry needling, is because it implies that I'm doing a ton of trigger point and a ton of pistoning techniques. Pistoning techniques are very sympathetically stimulating depending on how they're performed. They often make my patient very, very sore. And I have heard anecdotal evidence, right? Because in the States, I don't know how you guys do trigger point stuff here, but I mean, in the States, it's seek and destroy. You like stick that needle in and you just kill that trigger point until it's dead. And it's very, very aggressive. So when I tell a client that I want a needle, they're like, no, I've had that before, I'm not doing it. I'm like, give me a chance, right? Because they've usually had a really negative experience with it, which is unfortunate. So, and again, I'm often working in an in-season situation. So if I make my patient sore to the point that then he doesn't want to train or compete, that's always a negative as well. So really, I do mostly winding, which I know everybody in this room does as well, right? That's the qi that everybody wants to elicit and is considered necessary for acupuncture analgesia. The other thing with winding is that we stimulate mast cell production in the area that helps mediate inflammation. If you go back to that HPA axis thing that we talked about, if we can stimulate mast cells drive cytokines drive the HPA axis, which takes us into an anti-inflammatory state. Really, really nice. So when I wind my needle a little bit and I can help with a little mast cell stimulation, sweet, that helps me with my moving to resolution faster. And then also, we're getting this alteration in the extracellular matrix that can affect collagen of the deep fascia and helps perceive decreased muscle stiffness, which again is really, really nice in my clients who are telling me that their legs feel heavy, or if they're a thrower, their arm feels heavy. So if I can have a perception of decreased stiffness, that usually goes over really, really well for my client. Now, an actual decrease in their muscle extensibility and stiffness may or may not be a good thing from a power production standpoint. But that would be an interesting study to see if it actually does change their stiffness in their tissue and how that affects power production. And then utilizing distal points. I utilize distal points all the time. When I'm doing recovery and regeneration protocols, which I'm going to go into, I try to stay out of the hands and feet as much as I can. We all know lots of nerves in those areas can be, again, very sympathetically stimulating. But we know that when we add needles to distal points or areas that are not involved in the pathology, that we have this fantastic supraspinal pain management level as well. And really, it's all about root and branch, or cause versus source. Needles for me are an extension of my physical practice. So just because I have a needle in my hand, again, doesn't change my philosophy, right? My philosophy is always unwavering. But when I do have a needle in my hand, it doesn't change how I approach my patient. When someone comes to me with elbow pain, I'm always evaluating their shoulder, their cervical thoracic junction, their thoracic spine, their cervical spine, their wrist and hand, what's going on. Because I know this is the source of their pain, but the cause of their pain is from other places as well. So in the States, again, a lot of people like to stick needles right in the area of their pain, and they don't go to the cause of the pain. But yet you take the needle out of their hand, and absolutely, they'll do a kinetic chain assessment all day long. But you put a needle in their hand, and all of a sudden it changes their treatment approach, which doesn't make any sense. So you guys know we always treat both cause and source of the symptoms, cause and source of the pain. And again, I don't care if you're using traditional Chinese medicine philosophies there or Western medical philosophies. Either way, it's always interesting when you see these absolute overlaps, which is lovely. Dosing. The number of needles that we use. This is really key for me. And I'm sure key for all of you, right? What's the minimum effective dose? Because again, the goal is not to stick needles into people. The goal is to try to make my treatment as efficient as possible. But we know if we utilize needles throughout the spinal segments, we might help with some analgesic effects, which is great. Frequency, this is really dependent on how my athlete responds, their competition schedule for the week or for the month, and still sort of trying to figure that out as far as like what's best. Some guys really love being needled pre-game or post-game or on an off day only or whatever it may be. From a recovery regeneration standpoint, the protocol I'm going to show you is always done post-competition at night before they go to bed. If I do what I'm about to show you pre-game, it doesn't go over very well because usually they're super sleepy. And then how long do we leave the needles in situ? We know somewhere around that 20 to 30 minute timeline is really sort of necessary. However, I definitely get results with shorter times. My guys, you think I have ADD, my guys, they're all over the place. So if I can get them to lay down for 10 or 15 minutes, I'll take it. And I'm still getting good results, right? So again, what's our minimum effective dose there? Not really sure. So what do we needle? So, like I said before, I'm a professor at A.T. Still University, and I teach in the athletic training program there. And I teach in the doctoral program. So the beauty of that is that I have all these graduate students and these doctoral students that have to just do what I say, which is fantastic. And so they get to do the research that I want to do. I love it. So here's one of my doctoral students, Brian, and we're looking at this at the University of Michigan with their hockey players. And so as we were looking at the use of needles from a recovery and regeneration standpoint, we're looking at it, and there's no reports that describe a systematic technique for dry needling, acupuncture, recovery purposes only. And there were only a few studies that described any type of subjective outcomes of patients in the literature when it comes to recovery or how people felt. So there's a lot of people in this room that do way more research than I do. So if my doctoral student did a really bad lit review, let me know. He will fail. And I would love to see those studies as well because yeah, there really is. We know all of these things from a parasympathetic and anti-inflammatory standpoint, but yet we don't really have any studies to kind of help dictate how do we best practice. So we have to go off of anecdotal evidence. We have to go off of clinical experience, and that's what I'm about to share with you. So these are the things that we're going to do with the hockey players, looking at the acute recovery stress scale, the short recovery and stress scale as well. So my company, Structure and Function Education, like I said, we do teach needling in the States, and this is really our philosophy. And so for me, this is really the source of people's pain. So if I want to put a needle at someone's muscle, capsule, tendon, ligament, I was really, really happy to hear Kevin say that he's needling tendons this morning, because I needle tendons all the time, and I was like, ooh, is that like a thing we're not supposed to do? Like, it's controversial. Bone, meaning periosteal pecking, all of those sorts of things. These are very, very local and source type things for me. Everything else on our pentomodal method is about treating the cause of what someone's dealing with. So do we do something perineural, whether that's with ultrasounded guidance or through the dermatomes or myotomes or sclerotomes or viscerotomes or however we're going to alter that afferent input into the system. We know that's an important thing, right? Those of you who did the virtual reality thing last night, you knew you were only standing on a 1-inch board, but that input was freaking you out, and you were like, I'm gonna die, right? Because your input dictates output every single time. So we know this alteration of afferent input into the system. The needle can give us a really novel stimulus to do that. Central stimulation, I kind of follow Dr. Gunn's approach on that as far as stimulating centrally in order to sort of decrease pressure on that nerve root and hopefully decrease any pain points, which most would argue that an active trigger point is really a musculoskeletal expression of a neurological problem. So if we can get those spinal segments to relax a little bit and take pressure off of those nerve roots, we can theoretically help that pain as well. These are really the two that I want to focus on for the rest of this talk. These primary passive trigger points from Dr. Dung, as well as these fascial lines or fascial points from Luigi Stecco. Has anyone done the Stecco stuff in here? Anyone? One person? Two people? Okay, very, very cool. We're going to talk more about that. And I'm really excited because from here I go to Venice. And I have a week off in Venice, which is going to be lovely. But then I'm taking the fascial manipulation class with acupuncture from the Steccos. So I apologize, because this talk will be way better in a month. But I'm going to tell you what I know for now and just know that there will be more coming. But let's look at these primary passive trigger points first. Has anybody read this book from Dr. Dung? So Dr. Dung is a Western medical acupuncturist. And what he did was he took 221 of his patients and he palpated them in 110 spots. So everybody, this is going to be super scientific. Go ahead and bend your elbow and find that little tender point right in your elbow, in between the brachioradialis and the extensor carpi radialis brevis. I think you guys all know that as large intestine 10, right? I'm learning my acupuncture points. I'm trying. I really am. But I just don't talk in acupuncture points because I will lose my license. So to him, he called that the deep radial, right? Because we know the deep radial nerve is underneath there. So he calls that the deep radial. And for him, that's point number one, because 99.5% of his patients were tender there. So then everyone go ahead and palpate the olecranon. Let's say you have a raging olecranon bursitis, probably not super tender, right? Okay, so for him, that's point number 110. There was only like 0.5% of his patients that were tender on that spot. So he did this, 221 patients, 110 different palpation points, and divided these things into 4 different categories, of primary, secondary, tertiary, and non-specific points. And so these are the primary passive trigger points. And he's named them, I think pretty much every single one of them is named after a nerve. So these first 24 points were brought to my attention, and I thought they were very interesting. And now you have to remember, I have zero acupuncture background, right? So you have to forgive my ignorance. These points are being presented to me. I'm like, oh, these are cool. They're all named after nerves. And I have no idea about the association with acupuncture points. I do now, but I didn't then. So these are the primary passive trigger points. There's 24 of them. And these first 24 points he finds are very interesting because what he talks about in his book is that they progress in a painful palpation state, either in a very systematic way or a very random way. So when someone has, let's say, an ankle sprain, what he found was that these primary passive trigger points became tender regionally, meaning ankle sprain, the ones in the lower leg became very tender. So things like the deep peroneal, the tibial, the saphenous, the common peroneal, these all the iliotibial band, these all sort of became tender on people who had a very local injury, but none of the other ones did. However, from a systemic standpoint, when patients were presenting with systemic disease, he found that they progressed in pain in a very specific order, progressing from 1 to 24. So if all 24 points were tender, they were a bit more sick, if we can kind of utilize that term. And what he found was that these systemic points, or the systemic application of these things, happens when there's an endogenous issue going on. And so I started to apply that to the athletes because under recovery is absolutely an endogenous issue. As a physio, I was taught if someone is in pain, I can evaluate that injury, I can prescribe treatment for it, and I move forward. But what happens when your patient or your client comes to you and they just say, I'm tired, my legs are heavy, I don't feel well? Well, you guys from a traditional Chinese medicine had a way to treat that. For me and my really myopic Western background, I had nothing to treat with these people. So I began utilizing these 24 points, and sure enough, found some really fantastic results. And when you guys see the points coordinated with the acupuncture points, I think you'll understand why I had those good results. Okay, so file that away, right? So in our little file, we have the HPA axis, we have the cholinergic, anti-inflammatory pathway, and now we have our 24 points. So all those things are being filed away. Stay with me, they're all gonna come back. Now we have our fascial manipulation, we have our fascial points. So from a stecco perspective, and I've studied their stuff quite a bit, I'm certainly not an expert, but I spend a lot of time looking at his stuff. And so the term fascial points is a misnomer, right? Because fascia is everywhere. So what do you mean, these fascial points? So let's go into his definitions. Number one, he talks about center of perception. That's where someone's pain is, right? That's the source of their pain. Great. So then we look at these centers of coordination. So what centers of coordination are, let me give you an example. So think about ankle plantar flexion. So what causes ankle plantar flexion from a muscle standpoint? Not a trick question, I promise. Gastroc, right? What else? Soleus. Oh, you say it so nice. I say soleus. Soleus. What else? Tib posterior. Absolutely. Tib posterior. What else? Flexor hallucis, longus, right? Flexor digitorum. All of these synergists to ankle plantar flexion. So what they did was they did a biomechanical analysis of all these things that cause ankle plantar flexion. Really? Okay. Thank you. Ankle plantar flexion, all of these things that cause ankle plantar flexion, and they did a biomechanical analysis and came up with a center of coordination. That center of coordination is right at that musculotendinous junction at the gastroc. And what they did was they named that retro for the retro movement, right, plantar flexion, tally for the ankle, so retro tally. And what they did is they did that for the anterior side, the medial side, the lateral side, the internal side, and the external side. And they did that for every single joint in the body. Then what they did was they took all those centers of coordination and did a biomechanical analysis to create these vectors. And these vectors are called centers of fusion. And these centers of fusion are spirals throughout the body. Very, very interesting. So now, in his opinion, and in their opinion, if we treat these sort of keystones, for lack of a better word, of the fascia, it can really have a nice general systemic effect on all of the fascia. Okay, so when I'm in situations, because I can't needle in every single state in the US, every state is regulated. So when I'm in a situation that I can't utilize a needle with somebody, I go to these fascial manipulation techniques. The problem with these techniques is they're really, really hard on your thumb. And I'm old, and I don't like my thumb hurting from manual therapy anymore. So what I started to do was drop needles into these points and do some winding and see what happened. And sure enough, I was getting some really, really nice results. So as we look, right, so here's a outline or a picture of these fascial points, which looks rather familiar if you look at some of the details of it, and started needling these points. So then I'm taking this fascial manipulation class in Virginia, and then I immediately come over and do one of the acupuncture classes with Mr. Hobbs. And as he's going through and talking about different acupuncture points, I'm like, oh, that's a fascial point. Oh, that's a fascial point. Oh, that's a primary passive trigger point. Oh, that's a fascial point. I know all these points. I just don't call them the same thing that you're calling them. Very interesting. So as I began to look into these things a bit more, this is not new stuff. This is a study from Langevin and her group out in Harvard. She's been looking at this since 2002. I am just late to the party as usual. And what she started doing was looking at what acupuncture points are under diagnostic ultrasound. And sure enough, she started to find and makes the observation that over 80% of acupuncture points and 50% of meridian intersections of the arm appear to coincide with inter or intramuscular septum or connective tissue planes. Interesting, very interesting. So now, as we begin to look at these two things and we overlap these fascial points with these acupuncture points, there's such a huge similarity to it. And I'm so excited to go to Venice next week and learn a little bit more about this. So here's this chart that looks very scary, but it's not. These are the primary passive trigger points that I told you about, right? That I would needle these 24 points in my clients. And then sure enough, when you look at it, they all absolutely overlap with acupuncture points. No wonder, right? I think large intestine 4, large intestine 10, gallbladder 34, liver 3, right? These are all points that you're naturally using anyway to help with people's overall pain and overall inflammation. And I just was approaching it from this perspective, from a neural perspective. And then when we start to look at it, all of these fascial points overlap completely as well. And so I don't care if you want to speak Chinese, Latin, or Italian. Everybody's saying the same thing. This point's important, and it's important for something, whether it's pain control or inflammation. And I think that's absolutely fascinating. So continue to bring this back. The cholinergic anti-inflammatory pathway, the HPA axis, we have a neural way to immediately decrease somebody's inflammation by stimulating acetylcholine, by deactivating macrophages, by stimulating this HPA axis from a hormonal standpoint, from cortisol modulation, and then again, moving to this process of resolution faster, stimulating the vagus nerve via acetylcholine, which is absolutely huge. And our patient-reported outcome measures are fantastic. I have a lot of N's of 1. Oh, journals don't like N's of 1. But there is a comeback right now in the States for case studies and case series, which is making me happy. So yeah, the patient-reported outcome measures are fantastic. They know it because we'll do needling sometimes pre-game, and then we'll do needling sometimes post-game. And the last guy that I worked with, his exact words to me were, "Why do I get tired when you do these points? And why do I not get tired when we needle before the game?" There it is, right? Really, really interesting because they are just, I think, this immediate reaction here is helping them move through inflammation. And we're stimulating that parasympathetic nervous system through that vagus nerve, which I think is really, really important. Lots of decrease in medication use. So when my guy walks out of the training room and he walks past the team physician and doesn't ask for an Ambien for that night, super happy. That makes me super happy. So even if that's one guy that I can decrease his Ambien intake, I'm going to do it. Fantastic. And then again, the reports that their legs are less heavy. Their arm feels less heavy if they're a thrower. They just subjectively feel better. So these are some of the points. Basically what I tend to do is I do the points in supine first, let those marinate for 15 or 20 minutes, however long they're going to let me allow them to marinate. And then I flip them over and do them in prone. I always kind of want to see how they're reacting that day, if they're going to cramp. I've had an athlete who I've needled post-game, and I didn't realize how dehydrated he was. That's my mistake. And so he started going into full body cramps while he had needles in. That was not a fun time. So I like to kind of see how they're reacting and how they're feeling. And then I flip them over. And then really, quite frankly, from an anecdotal standpoint, I have significantly decreased the numbers of needles I use for this protocol. So even though I keep saying the 24 points, these 24 points, I've really kind of gotten down to just doing large intestine 10, large intestine 4, and then doing the primary passive trigger points in the lower body, and I'm getting just as good results. So that's great. I've eliminated probably a dozen needles, which I'll take. What's the minimal effective dose? I don't know. I'm going to continue to play with it and see how guys continue to react. And I think we'll get some more information once my doctoral student continues to work through his stuff. So ultimately, we've got some vagus nerve considerations, and the vagus nerve is obviously the key to that parasympathetic stimulation. If we can stimulate these large nerves, which I'm really excited to hear Gus talk more specifically about later this afternoon, it's going to be fantastic. But we can modulate cortisol via this humoral pathway and by the cholinergic anti-inflammatory pathway. And then if we can deactivate these macrophages, get them out of town, make the body realize, hey, inflammatory process is over. Time to move on. Really, really nice. So again, stimulation of these 24 points, but ideally and most likely probably less, is a really fantastic way to accomplish these things. We definitely have to consider, again, this overlap of acupuncture points to fascial points and to primary nerves. I think this is a really exciting time, right? The fact that we're able to start to see that everything that's been being said in traditional Chinese medicine is really being able to be backed up by Western medical science is really, really exciting. And we can always go back to our traditional Chinese medicine when we need to, right? In the absence of some of the Western stuff. And then we have to still consider what's the best locations, what's the best time left in situ, the location. Do we utilize eStim? So much more left to figure out from a recovery and regeneration standpoint with the athletes, but we're getting there. I think it's a really interesting place. There's your bibliography. I've added a few. I will definitely send this presentation so you guys have the updated slides. That's my contact information. I do stay in touch. Like all of us, I get slammed in behind an email, so don't yell at me. Like, don't send me a second email like in 12 hours later and be like, why didn't you answer? I promise I will answer. But yeah, I would love to stay in touch. And again, just absolutely thrilled and honored to be here at the AACP 35th anniversary. So thank you guys so much. Appreciate it.